Welcome everyone to the first session, the first MIS session of 2025. So the topic this evening is lateral hip pain. Before we begin, I just want to acknowledge that we are on the traditional lands of the Awabakal people and pay my respects to elders past, present and emerging, and to any Aboriginal and Torres Strait Islander people with us this evening. I also want to acknowledge our sponsors. We have New South Wales Regional Health Partners who fund a lot of the activities that we do as a network. And this evening, our major sponsor is Hunter Imaging. So we have Fiona floating around somewhere, or she may have gone home with vertigo. And she's got a little bundle of referral pads and goodies and stuff at the door if you can help yourselves. We have the gentleman from OPC Health with a stall out here just showcasing some of their goods as well. And obviously the University of Newcastle have partnered by giving us the facility to work out of this evening. For those of you who've been to these evenings, you know how they work, but for those who are new to this, I'll talk you through the cycle of how these sessions work. It's not just a lecture. What we do is we interview a bunch of clinicians leading into this event and we capture some key issues that we all face when we're treating people with lateral hip pain. So we identify some gaps, some inconsistency in care, divergent views, and where the care is maybe not up to standard with what the evidence says. Then we bring in an external researcher who might have some really good pieces of evidence that they need translated straight into clinical practice. So we provide that platform, and also we can marry up where the gaps in our knowledge and the inconsistency of care are and get those recommendations straight from the expert. So we've got Angie here doing that with us this evening. We pick some local clinicians who might have a special interest in this particular area, and we get them to develop the content. So they learn the up-to-date evidence and we keep that local knowledge here in Newcastle. So rather than just bringing in an expert, they come and teach us and they leave again, we develop our own people here. We deliver the content this evening and then we try and create some type of output afterwards to create some sort of meaningful change in care and meaningful outcomes for our patients. So what did we find when we interviewed a bunch of you? And thank you to those people who got interviewed by Andrew and myself leading into this event. We found that there's lots of inconsistent terminology being used, lots of different tests are being used. Some people say it's a really easy condition to diagnose. Some people say it's really hard to diagnose. And some people are saying, oh, it's really good. I know exactly what I need to do. I'll just read the image and that tells me I need to have an injection. Someone else says, no, that doesn't work that way. You've got to do this exercise. It's a bit confusing. There's not really a great consensus about what we need to do to manage this. Also trying to fit in, where does orthopedics fit, where does sports medicine fit, how does the GP work, when do we image these things, how much emphasis do we place on the image? All of those themes popped up. So we're going to talk about that this evening, and these problems, hopefully by the end, will become pretty clear to us. I'm going to introduce our presenters this evening. We've got Dr Andriy Boyko, who I still think is a local. So some of you may recognise Andre and have worked with him when he was here in Newcastle. He's a sports and exercise medicine physician and registrar, finishing his last bit of training up in Port Macquarie. And Andre will say that he loves treating athletes, but he treats his fair share of old biddies with lateral hip pain. So I'm looking forward to hearing Andre's point of view and expertise this evening. Cate is a dual titled musculoskeletal and sports physiotherapist. She's got over 20 years of clinical experience and she's worked in lots of physio places all over the world and brings a wealth of knowledge. Cate's also done some research in the LEAP trial, so she's got lots of experience with exercise prescription and education of people with lateral hip pain in a research setting. Dr Lawrence Josey, I'm very excited to have on board as well, one of our local musculoskeletal specialist radiologists, and I particularly love reading Laurie's reports because he's sort of championing the not letting people rely on the imaging alone to diagnose conditions. So Laurie will report this fantastic, amazing descriptive thing and then be very quick to say, it's the same as the other side though, make sure you correlate it with clinical symptoms, which is really refreshing from a radiologist. And then last but not least, Angie. Big thank you to Angie, who's come all the way up from Canberra to help us out. Angie's a clinician. She's a clinical associate professor at the University of Canberra. She's clinician, researcher, educator, all the things that we want to do as a physio, and an expert in this area. So Angie did her PhD in 2011, finished in 2011, and part of my passion in doing this thing is to try and translate research into clinical practice, and it's taking 17 years or something on average. So I wonder how many things in Angie's PhD are still trying to creep through into clinical practice. So hopefully this evening we can provide a bit of a platform in a community and have some sort of local implementation of some of that stuff to cut down that time frame. So a little round of applause for our presenters, and I'll get Angie to come up to start this evening.
Okay, nice to see all these faces. I don't think I recognise anyone. Well, some of our graduates sometimes move up this part of the world, so I was a bit worried there might be some here. So just before we start, you said Cate has 20 years experience. We had our 40-year review this year. I think I'll win. So when I tell my first year students that, they kind of go, oh my God, you must be almost dead. Clearly I'm not, and clearly I still treat patients and I still do research, and I've had a pretty good time of it. So I was really pleased to see some of the results up there. I'm kind of going, I'm not sure if you can learn all that much, but hopefully you will. So I've got to talk about one of the common pathways that Nikki picked up when she was interviewing people was the pathway of your middle-aged woman who presents to the GP with some grumbly lateral hip pain and ends up having some sort of examination, because GPs are good at that sort of stuff, but can end up going to have imaging, ultrasound, X-ray, cortisone injection. Cortisone injections are great for short-term pain relief. They don't address the problem, but and I don't think I'm telling you anything new here, that pain will recur if they get some pain relief and they have a second injection, and then maybe they might end up going and seeing the physio. That's not really best practice, and we will talk about what we think the best practice is a little bit later. But I've got to give you a little bit of history. So the first documented case of trochanteric bursitis was in 1896, and when I did my PhD, I sent the librarians off on a long trek to try and find this article, which was great. It was about 2 paragraphs in an American Journal of Surgery or something. If we shoot forward to 1958, this is probably one of the key papers, Anderson and Hanover, where they were talking about how you diagnose trochanteric bursitis, because that's what they were calling it. And buried within that paper is a comment that there might be some tendon problem associated with this. And then nearly 50 years later, we kind of catch up and go, oh, maybe it's not just trochanteric bursitis, maybe it's something else going on. So when imaging became much better, when we got MRs and ultrasounds, it was much easier to have a look at what was going on there without cutting people over. So this slide gives you a little bit of an understanding of the prevalence of the respective conditions. So you can see I've got a number of references down here. Tendinopathy has the gluteal, glute or glute has the highest probability of being the underlying condition. Between 51 and 100% of the papers report that is the main underlying pathology. Now that might be histopathology, or it might be an imaging paper. The variation is because of the sample that they've chosen and because of the heterogeneity of how they diagnose the problem. So for a long time, people would diagnose it just by poking someone on the side of the head. And in fact, I rejected a paper last year when I was reviewing one that was the sole diagnostic criteria. No, 20 years ago, yet we would have gotten away with it, but not now. Bursitis. So there is bursitis in up to 20% of cases. But I'll note here that if you look at the histopathology, and these are slides from my own studies, so it's really fun if you like histology, it's really fun to do this. No evidence of inflammatory cells, so it's not inflammatory. Okay, so there's acute, somebody's got an acute flare-up, there might be a little bit of inflammation, but the bottom line is it's not an inflammatory type problem. And then look at this in one paper, and it is only one paper that's produced this, but they found 30% of their people had some thickening of the ITB. So, if we look at that, basically, most likely, oh no, we're not as likely to look at this. This is, again, the long paper, which is the one paper that talked about ITB thickness. They've broken it down. It's an ultrasound paper, it's not a histopathology paper. So we all know some of the issues with ultrasound, but we'll take it on face value. You can see that 8% had the sides alone, and about 40% had tendinosis alone, and then you've got some tears, or no isolated tears, but tears in both sides and tendinopathy in both sides, and some bitemporal thickening. So when we're seeing these people clinically, Andrei and I had a conversation on Tuesday night about whether you could clinically differentiate between tendinopathy and bursitis. To my knowledge, there is no evidence to support that we can do that. Andrei has a number of N=1 studies where he thinks he can, and I'm challenging him to go, okay, go off and do the research. Come and be a PhD student for me and sort that out. But at the moment, I think if you don't have a local anesthetic injection in your hand, unless you're a doctor, presuming most of us are very little physios, we don't have that luxury of sticking an injection overnight and just see what happens. So I'd be surprised if many of us can clinically differentiate that. But I look forward to seeing that Andrei's paper about this in the resource this time. I think it's all right if I don't get to it. I want to remind you that our patients come in complaining of hip pain. And I spend a lot, and it's our job to work out what they mean by that. So these pictures up here are from a couple of studies where they had people with local chairs and they stuck local anesthetic injections in to work out what was causing the pain and what was causing the pain. And so a lateral chair can give you pain in all these different areas. Noting it can give you that lateral hip pain. I spent months during my PhD trying to convince myself and my supervisors that no, the hip joint couldn't refer to the lateral hip because that was too inconvenient. Unfortunately, I had to succumb and go, yes, you can. So we can't rely on people saying, I've got pain here, and you're like, yeah, they've got growth drug pain too. Let's call it that for the moment. You do have to do some clinical tests and you have to listen to their history carefully about what they've talked about. So we're talking about, these are the kind of common history that people will tell us that women generally over the age of 40, in a ratio of 41 women to men, they're less likely to be in full-time work, although that's not going to help you with your diagnosis. They're often overweight, they're sleep deprived, they've got high levels of comorbidity. And in terms of their presentation, they have pain on the side of the hip, with lying either on it or on the ipsilateral side, and then the legs dragging on it, and that can give them pain as well. And they get pain with great bedding activities. It's not that much to go on. What they don't have, who can tell me what they don't have if they've got isolated gluten and pain syndrome? Yeah, they won't have back pain if it's isolated. Around the hip, what won't they have? Sorry? Groin pain. If they've got isolated gluten and tendinopathy, they will not have groin pain. I also want to talk to you briefly, remind you that we need to think about your players. This is an age group that have increased risk of having cancer. If they're older, like over 80, and they also have some fragility. So don't forget to do the red flag screening. So we're talking about the sinister pathologies: tumour, trauma, infection, infarction, inflammation, and that neuro one is because I said neuro at the wrong time, and this is pop that there, but actually it's over here.
I have yet to generate neuro.
Yeah. So these are the things we're thinking about, and these are the kind of things that will lead you to that conclusion. So past history or current history of cancer or family history of cancer, intractable pain and intrusive night pain. These people all have almost all have night pain, but if they've got off the hip, the pain generally goes away. They find it hard to sleep, but intractable night pain is that they can't sleep in any position. They have to get out of bed. They have to walk around. These people don't have that. Non-mechanical pain or their history is inconsistent. There's something not quite right in what they're telling you. You know that feeling in your gut when you're going, I'm just not quite sure what's going on here? Pay attention to that. Systemically unwell, fevers, malaise, night sweats. Physios are not likely to see this group of people, but sometimes they'll come to us before they've been to the GP. Unexplained weight loss. You might have somebody come in and say, I've lost 10 kilos. Really effective, it's unexplained. That clinical findings aren't matching the history. Progressive neurological signs, gait disturbance, they often will have a trend on their gait. That's not what we're talking about. We're talking about neurological stuff. Recent trauma, this is uncommon. I have had a few people with trauma issues. One had a avulsed canter, she was playing squash, and somebody tore her left knee lifting a suitcase off airport thing. But if they can't wait there, and hopefully they're not, they haven't come to us if they can't wait there, I can't do that. Rheumatologically inflammatory type conditions and age. If you have a young man who turns up with radial pain syndrome of insidious onset, I've been researching this for 18 years, formally researching it for 18 years. I've got 40 years of clinical experience. I have never seen a young man with insidious pain. If somebody comes in like that, I want your index of suspicion to be up through here. And a child. I have seen one child, but you can't move either. If you've got kids coming in to see you, and you can see the GP slides. So this is a nomogram. On the left-hand side, we have the pre-test probability. And basically, that's you going, I've got this person standing in front of me on a population basis. I'm going to assume it's a she. She's coming with lateral hip pain. Her history is consistent with lateral hip pain. How many people in the population do I think that have this story and likely to have GTPS? And you go, oh, well, I think if they've got lateral hip pain and their history is consistent, then it's probably more than 40%. But it's, chances, and they say they're in their mid-50s, peri or postmenopausal, then I reckon the chance of having GTPS without me even examining them is somewhere between 40 and 60%. Are people happy with that kind of estimate in my head? Yeah, so we're going to call it 40 because that's where the next square is. So maybe it's a younger person, maybe they're only in their 40s, so that probably down here. And I do a test that has a post-test, a positive likelihood ratio of about 18, and it's positive, so it's a positive likelihood, and it shoots that likelihood, that probability of them having GTPS right up to nearly 95. So what we're doing is we're using these tests to improve our chances of getting the right diagnosis. So a positive likelihood ratio is the test is positive, and that number is greater than 1. And the negative likelihood ratio is the test is negative. And it's less than 1. Because if it's 1, what's that going to do to our probability? It makes no difference. I start by going, am I happy that it's likely to be around the hip? If they've got back pain as well, I will look at that, but I'm not going to go into back and SRJ pain at the moment. You guys should know how to assess that. You need to just know that they can coexist. I then go, is it intra or extra articular? I'm very basic. Is it in or out of the joint? And if they've got good hip range of movement and a negative fatal test, it's not likely to be in the hip joint. Okay? Here is some likelihood ratios for hip OA, which is the most common comorbidity in this age group. And you can see that if you do these tests, they've got quite chunky, positive likelihood ratios. So if they've got restricted range of movement and they've got groin pain, they've got difficulty with their shoes and socks, it's probably the one. They may have glutial GTPS as well, but they probably got hip by way, and that might be the main problem. That was a very fine systematic review and meta-analysis that produced those numbers. This is a recent systematic review and meta-analysis on gluteal tendinopathy testing. I am going to use these numbers, but I want to point out to you that they've got some really wide 95% confidence intervals, and some of these meta-analyses are only done on two papers. So this paper suggested that if you calculate the graded trochanter as a nice positive likelihood ratio and a good negative one, and you do resisted hip abduction, that should be your diagnosis. The reason I've got that one is because I've got 5 papers and there's other ones that I've got a couple of papers. In my clinical experience, which I've just indicated to you is quite extensive, resisted hip abduction doesn't help me very much. So I've gone back to all the papers and I've looked at them and I've done this for you. Can people access these slides later? So I've used a pre-test probability a bit higher than the one we talked about before. And over here I've got the negative likelihood ratios, and over here I've got the positive ones. So if you've got someone with lateral hip pain and they've got a positive GT palpation, that boosts your post-test probability to about 80%. And if you add any one of these other tests and they're positive, you're looking in the high 90s. Now we could get quite complicated and say, well, what if some of them are negative and some of them are positive? And that's a good thing to think about. You have to do, what do we call it? Spidey something.
Spidey sense.
Spidey sense. I'm going to call it spidey sense. You guys do this all the time. You do a series of tests and you go, oh, this one's positive and this one's negative, but more of them are positive than the negative ones. So I think it's an ACL injury, or I think it's spondylolisthesis or something. We're just doing exactly the same thing. So treatment pathway, Kate's going to talk about this and Andrew's going to talk about this in more detail. But in short, really important to build the therapeutic alliance, almost above anything else. If you don't have non-water, and somebody talked about that earlier, then you're not going to get very far. Have the client-centered approach, work with them on their goals, address their individual impairments and comorbidities. So yes, we've made a diagnosis, great. Now you've got to think about what's wrong with the person in front of you. The result may be a little bit different. And set some time frame expectations. If they think they're going to be better in 4 weeks, then you're fighting a losing battle. And if they're not progressing, they should be progressing, and that progress stalls, then you need to reevaluate your assessment and your management of that patient, and we have some talk about that. This is a paper published recently in Journal of Physiotherapy with open access by me. And this is basically the levels of evidence. The darker the green, the higher the quality of the evidence for these various treatments. There, done. I just got a little bit of time.
Thank you, Angie. That was great. Before I move on to my talk, I'm going to skip through the slides fairly quickly. But I think the key thing about that diagnostic overview that Angie presented, those numbers are up in the high 90s. So really get that number in your head for the numbers that I showed, which are in the 70s and 60s for the early user. That's going to be the crux of my talk. So that's why I said Angie's key points with those factors is really important that those numbers are up in the high 90s. So really remember that. I just want to say thanks to the group that I work for. This isn't a sponsorship, it's just a reminder that they've got a lot of scanners that are really, really good. They've got high quality 3D scanners, which means they can get the scans done really accurate with a high degree of resolution. Scanners vary from 1.1 to 3. The quality is not the best, it's how the scanner's used, and they use the scanners really well. So we've got really, really great technical staff running them. And if you ever need addendums or imaging review, I just wish I could just be more on this or that. You can just write out a request form and just fax it through and say, look, can someone have a look at it? Attention musculoskeletal radiologist. We've got a great group of guys, Colin and Dash, the whole team. So you can usually get that addressed. You might take a second phone call or a follow-up phone call to say, look, I sent this request for a second week and they'll get sorted out the actual point. During one year, this chat on imaging is really going to focus on exactly that, the lateral hip. The hip is a very complex structure. When I'm having anything to do with patients or mine, the joints are like important, it's like the brain or heart. That's why the joint is very hard to work out the answers to the problem. For this talk, we're just going to slice off that far outside bit. So I'm not going to make it any more complex with the internal components. And when we slice off the outside of the hip, which surgeons can does quite regularly, Andriy, it really is just a whole bunch of type 1 collagen, just in a few different shapes. And if you think about that, type 1 collagen, the 3 tendons, there's not a lot of tissue there. So when that worry starts to creep in, if there's no red flag symptoms as Angie into that, we really don't need to be pushing down on the image. And have confidence in that moment in the pain because there's no complex tissues there that really cause any trouble in reality. Unless you've got red flags, I'm not talking about. Again, the collagen is very wide, both at a cellular level and
Unless you're in the
and honestly, for us looking at the imaging, you probably get that in the reports. It's there's not much to say there. You know, the most we get is 3 grades. You know, normal, not quite normal, and there's care of some sort. About as much as you ever get. Think of all the reports you've ever read. That's all you ever get. When's the last time you got cancer or anything? It just doesn't happen on the outside. There's no high turnover cells out on that. Again, as Angie hinted that, refer the pains along. It's a different discussion for what we're talking about today. And again, just ultimately, more imaging. I just made reference when we were talking about this talk, Angie, how many pictures of lateral hips I've seen over the time. It's a really common condition. It gets imaged a lot more so 10 to 15 years ago than now. But ultimately, I don't think I've ever seen anything surprising like yet. Really have. In the MRs, I have when we're looking for other conditions, absolutely. But just the ultrasounds or the MRs just with lateral hip, I haven't seen anything unusual. I tried to look for cases and it just doesn't pop up. So what that says is that the imaging isn't that good for the lateral hip pain for that specific diagnosis. You've already got it right clinically, as Angie looked at. There's a 98% chance you got it right. And I thought, well, that's why I'm not seeing anything interesting like these lateral hip scans, because you guys want to got it right. We're just looking for reassurance, which you probably don't need to do anything. I think that's a good statement to say. It's have confidence in what you're doing. Again, the numbers that I think that I wanted to reiterate was that if you just spend a little bit of time just looking at this is and Angie's an expert in the data, and Angie popped this paper up for me, which is fantastic. So the sensitivity means we guess a lot. Specificity is we kind of almost get it right sometimes, and ultrasound's pretty much the same. Okay? This is because the imaging is subjective, and generally the performance of the test, the ultrasound and the MR, it performs better with worse quality, right? So if you've got a bundle obvious test, if it's a no-grain image presented, it's going to be up in the high 90s, which you're already at clinically, because there's a large care there to be honest clinically. So you don't need that imaging early in the process, all right? Have the confidence in the diagnosis that we make. Looking at both MR and ultrasound, they have a similar performance for the tears. So you're thinking to yourself, look, I just want to find that tear. So the tear is going to impact on my treatment or how much the patient do, what sort of referral pathway I'm going to have. MR and ultrasound similar performance. So you can choose either one you like, that's fine. If you just want to pick that one, don't mind. There might be a reason for the MR, you want to exclude some other things, different age bracket, preference, your choice. The worse the symptoms are, so the more of those diagnostic tools that are applied to this patient, the more accurate the test is going to be. So you choose either one. You're going to set the tear. Anything less than a large tear, though, both those modalities start to become really limited bias. And that's when we start to get all this jargon that you read. And tendinopathy, partial fall, that. Essentially, what we start seeing on the pictures is we're seeing structural changes around there. And so we use a variety of terms across all of our piece. We don't have any standard training in this in terms of non-musculoskeletal. Musculoskeletal guys tend to be familiar with literature and terminology. And we try to lead more towards tendinopathy, try and describe things that are useful to you clinically. And moving beyond the terminology, in general, I think MRI tends to identify tears more readily, the large tears, and also because of the atrophy of the muscle bellies. Just to give you an example here, this is exactly what we see on the scans. This subjectivity that I was hinting at. So this is a patient who's already got a 98% probability of being a problem tendinopathy. We really don't need these scans done. But when they are done, this is a tear. This is tendinopathy. Good luck with that. I still can't tell the difference. And that's why that number is between 70 and 100%. Yes, really, it's part subjective guess. However, the MR got fluid. Okay? Normal, fluid, MRI is a lot of that. What if the type 1 collagen is abnormal? The MRI can see that objectively. Okay? So just give you something objective to look at. That can be reassuring if you want to find out large scale. In general, ultrasound, I think, absolutely has a role. There's no doubt it does. But I think the role is very specific. It's in that case where you're not entirely worried about it. Patients sometimes like to have the imaging, that's fine. If we're dealing with the patient, like I say, you've got to engage with the patient, they want some sort of imaging or some sort of guidance tool beyond your confidence, that's fine. Then you can use the ultrasound, expecting to get that terminology which will match with your you can use the ultrasound if you want to find a large tear, and absolutely see a large tear. See what we call a bare trochanter or bare facet, no tendon facet anymore. And then simply a worried patient, and otherwise, ultrasound really has to be used for that limited specific purpose. Don't use it for anything else. Just think in your head, I'm not that worried, I want to see out the ultrasound. That's it, if you really need it. MRI, otherwise, really is the only choice when you're considering alternative pathology. X-ray really is only for disasters. I just really want to stress that, is that the amount of times I've seen significant pathology after an X-ray, but 3 months later. It's so what they've done is the clinician has decided to use X-ray as that screen tool to get rid of the bad stuff, the weight loss, the night pain, the fracture. For some reason, you'll think fracture X-ray. X-ray is the fracture in the legs. Patient can't walk and coming from the trauma, that's fine. You want to get an assessment of what's going on. But in the outpatient setting, looking for a fracture, if someone who's walked into the X-ray place, we're probably not going to see the fracture in the X-ray most of the time we've done. Okay? So just don't do the X-ray for the bones or for those with conditions. Go straight to the MR. That's what the tool is in 2025 is the MR for those problems. Beyond ultrasound and MRI, EOS is a fantastic test in terms of the biomechanics. The biomechanics, of course, I'm not an expert in it. You guys are absolute experts. How the biomechanics relate to the kinematics, that's your own narrative. You guys choose the EOS will absolutely give you those parameters. It's a really, really great tool. I'm pretty sure 100 is the only one that has them. I think they're worth $100. It's a pretty expensive piece of equipment, but amazing technology. So that's available for your biomechanical assessments. Just to touch on kids, as Angie said, the lateral hip pain in kids is really unusual. The only catch is kids with significant pathology, they tend to refer pain everywhere. It's really hard to work out. Try and work out pain in 8-year-olds. It's impossible. Use the MR early in kids. If you don't have access to the MR, work with the or work with the referral doctors to get the MR access. That's really critical. And ultimately, when the image, it's just this slide is busy, but it's just to reiterate again, to summarize, is you don't need to be early in lateral hip pain, as Angie said, because the mammogram application is far more accurate than any imaging. And that's definitely improvement, not papers and papers that you've got. So have that confidence. Don't use lateral hip pain early. If you want to find a tear, the ultrasound or MR, note that MR will be less subjective and it will show you the atrophy of the muscle. The ultrasound won't do that. Okay? Once you consider those two concepts, if you want to exclude the bad stuff, go to the MR. Right? You can use the X-ray to with the LA. You think this is an eye complicating picture, you can do the X-ray, but during the when we want the MR. Anything else that might actually be unrelated. For radiologist jargon, you can help us with that in one context where if you give us a concise history and you ask a question, we get an answer to that question. If you have a long differential, we have a long list. That can be different for everyone. Generally, I'll just ask to mention this, but I just don't think there's a role, maybe if we go back to 20 years ago, I just don't think there's any role for radiologists, unless you know them well and you're in a close working relationship. If they suggest to inject, just politely ignore that. I really would suggest that. I think it's an outdated thing for us to be doing, unless you know the radiologist and you work closely with them. And the concept of bursitis really should be moving out of our vernacular. But again, it's just things change. Things take time to change. So as long as you understand that when a radiologist says there's bursitis there, what they're really saying is just there's structural change in that anatomical feature. It's not normal. Probably relates to lateral issues or tendonitis or something. Again, some people have said to me, "Well, you find imaging, you change the X-ray to something else, or et cetera, et cetera." It's not our role. We do sometimes. If we're going to hit for a second hit and they're 8, then I don't worry about it. We're still in the or if you get a kid for an ultrasound, there's a big pussy fluid there. So we go to the bar, we get a lady who comes in for an X-ray, question mark stress factors like, look, we've got time to do the MR for it, otherwise let's say X-rays are not helpful. Just do the MR and what we can. But we generally have to do the imaging that we've been asked to because this is a key thing. Medically, professionally, individually, it's just a disaster if we've missed something. So if we send in an X-ray and ask them for sort of stress factor, it's not the right test. We'll always do the X-ray. Hopefully you get clarification saying you can't exclude the stress fraction on the X-ray. You won't see it, so it's a complete fraction, an issue. But we still have to do that imaging for you. And just a couple of examples, just for in your clinic, if you are getting the MR done. Again, slicing off this lateral hip, you can see how much we slice off to get the lateral hip out here. Okay? The only thing here is these 3 tendons. This is axial view. This is a glute min at the front. I generally tend to find that there's 2 heads of glute min. There's a sort of a lateral posterior hip and a gap in between the 2. Just on note, this is one of the reasons where ultrasound overcalls by tears. This ultrasound will see these gaps and call them tears, but really there's no tear there. And the key thing with the MR again is just this low signal. So the type 1 collagen is really tight. There's very few cells. There's no water in it. There's no mucin in it. And therefore, MRI is a water map. So that's what makes it excellent for finding pathology. It's very, very sensitive. But the catch is to determine the significance of the sensitivity. You can see over here all this water in the human body is still normal. Okay? But again, these low signal tendons. And just to finish it up, just to reiterate that X-ray is pointless in the context of lateral hip pain and in the absence of trauma or red flag symptoms. So it's not going to tell you anything that's going to be helpful at all. Even if we see enthesiophytes or hydroxyapatite, various bits and pieces of calcification around here, if we look at other parts of the body or other pieces, the same things will be there. There is a physiological innocent, there's a pathological. We can't tell you the features of the stuff that's there. The hip here in this example, the fluid in the tendon, this is the key thing. This is the tear. And then we have the tear here derided and then oversum. And so that's the end of my talk. And I'll hand over to Cate. And thank you for your time.
So thanks for everyone coming tonight, and so far for the people that have spoken. I'm going to focus tonight on the physio management of GTPS. So we're going to cover education, exercise, and appreciating tendon loading alongside the progressions and talking a little bit about load management as well. So education and exercise form the pillars for the management of GTPS. We know from landmark studies like the LEAP trial or the GLOBE trial that physiotherapist-led exercise and education intervention is first-line management in GTPS. And in the initial stages, it's actually more superior to cortisone injections or just wait-and-see approach. So I'm going to look mainly at education and exercise today, but I welcome any kind of discussion around some of the adjuncts, manual therapy, taping orthotics in the panel discussion in a little bit. So education is really important. It's multifaceted, and it's really important that we take the time to educate our patients thoroughly, allowing them to ask questions, and allows us to collaborate with them fully. We want to make sure that part of our education covers all of these components here, including education on compression, what compression is, how to reduce it, as well as activity modification that's specific to the patient in front of you. We want to address pain beliefs, as well as demonstrate to them and prove to them that exercise is really important and that they understand what that means, what the progressions are, and understanding of pain whilst exercising as well. So educate, what we've now learned through a lot of research is that greater trochanteric pain syndrome is quite complex, and it has lots of chronicity as well as affects people's quality of life quite significantly. Education is extremely important. It's been proven to, in a lot of literature, whereby researchers have looked at what patients believe is going on with them, and we're here to dispel some of those myths as well. So what we must educate our patients on is actually what's going on with them. What's the pathoanatomy? What is GTPS? We need to educate them on what load management actually is and what that means for them. This is really, really important. We do need to educate them on the benefits of exercise and what safe exercise is for each of those patients. We know we don't want them to do nothing. We want to tell them what they can do and what's safe for them. We need to educate them on positions to reduce compression, and I'll talk a little bit about that as well. We need to educate them on movement and postures and put that into practice with them clinically. And we want to educate them on safe levels of pain when they're exercising. It's a tendon problem. We know that there is going to be some discomfort while they are exercising, but we want to give them guidelines that they can focus on to allow them to exercise safely. What we want to modify or avoid is that we don't want to discount the chronicity and the persistent pain that these patients have and their beliefs around pain as well. We want to avoid and modify uncontrolled hip adduction with activity, especially functional tasks like going upstairs, walking, standing, or getting out of a chair. We definitely want to educate them on not having rapid changes in load, again, because it is a tendon issue. We want to educate them on positions of compression and how to reduce that, and I'll show you how. I'll demonstrate some of those. Also taking away hip adduction stretches such as your ITB or glute stretches, and we don't want to use negative language when we're talking to our patients about this. So with compression, when I'm talking about compression, I'm meaning the glute med, the distal end of glute med and glute min against the greater trochanter. We know that the ITB overlies this, and as the adduction moment increases, so too does the pressure and the compression of the ITB against these tendons. As you can see in the diagram, and those stretches, all of them have an adduction moment with them. And so they're going to compress those glute tendons over time with every time that these patients do this. So part of our education is to really highlight some of these positions that patients might be adopting. You might see them in the waiting room with their legs crossed, get out of the chair with their knees pressed together. And we want to start to put this into practice of modifying this and educating them on alternative positions. So if we think about reducing compression, with sleep particularly being one of the most provocative positions that patients report pain in, we can see in that first picture, the way everyone probably likes to lie is highly compressive. Then if we move across, we can modify that to improve someone's sleep by positioning them or educating them to maybe lie on their back with a pillow under their knees in slight abduction, or if they are a side sleeper, modifying that to lie on their side with 2 pillows between their knees, of course, with the affected side uppermost as well. And that can reduce some of the compression that they may feel with sleeping and hopefully maybe improve their sleep quality. So Before we move on to exercise specifically, I would love to dispel a couple of myths. The clamshell. So we love them, patients love them, trainers love them, but they actually have no place whatsoever in the rehab of glute tendinopathies. It's compressive. There's low yield of actual glute activity while doing that exercise. It's highly compressive, and obviously it's not weight bearing, which is really important for tendon health. Also, ITB stretching. Don't do it, okay? It essentially is compressing that ITB against the tendons, and you just repeating the cycle. So what we want to do is optimize mechanics with functional tasks like sit to stand. We literally want to train that in our patients immediately as soon as we see them. As Angie says, walking upstairs like a cowboy, so changing how people are moving. We want to control that adduction moment with movement. We also then want to follow some tendon loading principles and, of course, individualize it to a patient. So it's not that tricky, I promise. So if we think about progressive tendon loading, what we know, and we all should know about this, is we want to control those provocative tensile and compressive loads while exercising. We want to start to respect the tissue, build capacity, and then build resilience within that tendon. So if we've got someone who comes in, terrible night pain, really irritable, can't sleep, can't do anything, we might start down the isometric pathway. We know from the work of Jill Cook, Craig Purdom, Ebony Rio, that isometrics bring cortical inhibition and pain relief. We don't know the exact optimal dosing for our isometrics, but I do have some guidelines for you. The most important thing, though, is you want to educate your patient to do these correctly and, of course, in a position that's most comfortable for them. We can then move on to sort of our low velocity, higher tensile loading to build capacity and hypertrophy. And that's really best done in this weight bearing position. So we get high levels of glute med and glute min activity, but just being aware that we don't want to add compression to that. We need to give guidelines to our patients for pain and what's a safe level of pain to experience, as well as monitoring their load with 24-hour pain patterns as well. Now, specific exercise is great, but it means nothing in function. So we need to make sure that we have got some putting these things into practice with function. Correcting any aberrant movement patterns is absolutely key. It's quality over quantity, guys. You need to make sure that you teach your patients how to do these exercises and how to do them well. We want to start slow and simple, and we can build up to fast and complex. So someone with walking, we might start just on the flat with short walks, and then slowly build up to maybe getting them back to running, maybe up a hill, walking upstairs, if that's appropriate for them. So we put it into our tendon kind of pathway. We can start down at that, respecting the tissue, building all the way up to tissue resilience. So isometric wise, we're kind of working between that 25 to 70% of their MVC. That's going to depend on the patient in front of you and their irritability, okay? We're building up to 45-second holds of about 4 to 5 repetitions, multiple times throughout the day. What's also really important to note is that we want to give them a rest-work ratio of about 2 to 1. So whatever they hold that isometric contraction for, we want to give them at least double that time in rest between repetitions. We can then move on to build some load, where we've got those high load, slow velocity, isotonic style exercises. Our traditional 8 to 12 reps, 2 to 3 sets, 3 times a week, all dependent on who's in front of you. I unfortunately don't have a recipe for you. It's all about who's in front of you. If it's appropriate, we can move on to that energy storage phase of tendon rehab. But remembering the demographic of patients that we are seeing in front of us, we may not need to go up to our plyometric phase. However, it is recommended that patients still continue their isometric and isotonic kind of exercise program as maintenance for at least twice a week. Okay. So what exercises should you actually give your patient? So a beautiful systematic review in 2020 looked at all of the glute med and glute min exercises that are kind of around. And they rated how much activity was happening in those glute muscles with each of those exercises. So if we look at those low activity level ones, which is great for our initial patients who might be highly irritable at the start of their journey rehabbing, we're going to have things like freestanding squats, double leg bridge, double leg sit to stand. Of course, controlling any aberrant movement patterns and watching for that adduction moment. We can move all the way up to high load, where we've got things like step up and over, lateral stepping, split squats, hip hitch, single leg bridge, walking lunges, static lunges with a contralateral weight. Looking at that, you can see most of it is double-legged and then transitioning to single leg. So when we think about our exercises and the tendon together, we need to be mindful that we are aware of what's going on with the tendon and how much load each of those exercises are exerting on those muscles. So we've got clams. Hopefully everyone now knows don't bother with clams at all. We can start nicely with bridges, sit to stand, controlling any movement patterns, and then all the way up to higher load things like deadlifts, walking lunges, as I said before. So this is just a really nice example from a recent paper by Grimaldi. It was based on the LEAP study, exercises of a progressions. It's by no means prescriptive, but it is an idea of how you could progress patients. And this is a great paper that's been recently published as well. So when to progress and how to monitor load. This is probably the trickiest thing to do as physios, to stop patients from flaring up. So we know that we need to make sure that our patients don't have those rapid increases in load or activity. We need to make sure our guidelines are basically 10% of increase of load per week, and that's based off Gabbett's research. Our patients, and we need to educate them on their 24-hour pain pattern as well. So how did they go immediately after doing the exercise, that night and the next day? We can use the visual analog scale with the traffic light system for acceptable levels of pain, and any increase in night pain or pain the next day might be indicative that the load was too great and that needs modifying. We also want to work to, when progressing our exercises, which can be done at any time, that they don't exceed a 4 on the Borg scale of perceived rate of exertion. So exercises can be progressed as long as your patient can do them well. They're not going outside of those safe guidelines of 0 to 3 out of 10 on the VAS, and they're not reporting any more than a 4 on the Borg scale as well. So as part of our function, as part of exercise, we need to have a look at movement retraining. So a study in 2016 looked at the kinetics of walking with patients with GTPS, and what they found is they've got increased hip adduction moment at early stance phase, with a compensatory contralateral trunk lean and pelvic drop at late stance phase. They've got reduced cadence, reduced step length, and reduced speed with stairs. So as part of our job as physios, or anyone that's seeing these patients, is we not only want to strengthen them, but we also want to maybe not having them walk like Cate and Kel as well. So this is just, again, from that same paper by Grimaldi, a summary of some tips that might be helpful when working with patients with GTPS and some of their movement patterns. So things like holding onto a rail, walking up like you're a cowboy, standing up with your legs apart, and being light on your steps as well. So lastly, Angie's just recently put out a paper with some outcome measures that are great for gluteal tendinopathy specifically. If you're interested, then it's definitely worth a read, and it's quite comprehensive. So my key take-home messages, hopefully I'm on time, is that education is really important, and it empowers patients and makes them part of their rehab as well. We need to consider what we know about tendon loading when we prescribe exercise, and the types of exercises we're prescribing and how much glute activities happen. I can't stress it enough. You need to supervise your patients and teach them how to do these exercises really well. Keep them simple, keep them specific, and dose them appropriately. And of course, you need to monitor load and teach your patients how to do that, because there's absolutely no recipe for the tendons. Thanks. Pass.
I've been asked to go really quick, so feel free to ask me questions later. But I'm Andre. I'm from Port Macquarie. I did a fair bit of my training here, so I do have a few familiar faces here. And I think Nikki asked me to come and talk to you guys today from a sports medicine perspective, because Port Macquarie is known as the God's waiting room. And now I will talk to you about some of these adjuncts and how we approach these patients, but they're trying to go fast here. Oh, what happened here? So there we go. But the key is that picture on the right is very much my waiting room in a sports medicine setting in Port Macquarie. They're all elite bowlers with hip pain laterally. But it's essentially who I'm seeing those people who have failed that initial conservative treatment. So by 12 weeks onwards, there's still about 1/3 of people who continue to be symptomatic, and that's the ones that are coming to see me as a sports physician. And I know I'm going to talk about adjuncts, but I think that the important thing about what we can offer and work collaboratively with you guys and GPs is that we have time. So we have time not just for exercise assessments and quality assessments, but we have a look at risk factors. We can address them. You will be familiar that BMI is a really common one. Metabolic disease, there's developing evidence regarding hormonal studies, as well as biomechanical assessments and psychosocial. I think that's a really important one, because a lot of these people, by the time they come seeing you, they've had this pain that's been 3 months, 6 months, and it essentially puts them into a chronic pain patient. You know that their pain affects their sleep, that affects their mood, and we all know from chronic pain studies that snowballs and makes treatment of lateral hip pain quite difficult. And I stole this from Angie's paper, but just down the bottom there, in her 2012 study, she identified that pain, rather than the underlying pathology, was driving impairment that leads to walking and single leg dysfunction. So where we come in also is with time. So we have time to address that pain. We have time to educate the patient. We have time to collaborate with you guys, with GPs, and we have time to use adjuncts if the first line therapy, which is always going to be load management, has failed. This is how I feel when anybody asks me about PRP, and I'm the diver. And I think there's a lot of misunderstanding about PRP. I think, definitely in Port Macquarie, everyone just thought that's all we do as sports physicians. We just come in and just have a salvo of PRP in our pockets and we throw it at everyone. And that's not really the truth, and also not everything we do. When you look at tendinopathy adjuncts in general, there's quite a lot of them. And then when you actually look at the evidence behind adjuncts for lateral hip pain, and I'm going to say hip abductor tendinopathy, that list is a bit shorter. And the main thing that I want to stress is that they do have evidence, but the key is, when I see these patients, is I think of them as a toolbox. So for me, they're a box of tools, but what I'm trying to do is either assist them with managing their pain, assist them with managing their loads, or re-engage them with some form of rehabilitation. It's not a case of, oh, well, where have you been all my life? Have some PRP, you'll be better tomorrow, and thanks very much. So again, it comes with a collaborative approach with you guys. So saying that, these modalities do have evidence supporting the use in lateral hip pain. So I've broken down in non-invasive, so where we don't break the skin essentially, micro-invasive, where we use a needle, and then macro-invasive, so surgical. From non-invasive, and I think pretty much Cate, Angie, everyone touched on this, both qualitative and quantitative studies say that patient education matters, and not, well, education about quality of their rehab, technique, but also education about them understanding the pathology. When, from a qualitative point of view, patients identify the education as just as important as shockwave therapy, and then there have been quantitative studies that actually showed that short-term benefit of education, patient education, is as good as cortisone. And then that actually carries on beyond the cortisone period of effect of about 8 to 12 weeks. So why it's important for us is we re-engage with them, we reassess, and help you to maintain that compliance, but also with a system of adjuncts and education, we can empower them to build on the load management that they've started on. I'm going to run through the adjuncts, but I want you guys to remember that none of them, and this is definitely how I approach the situation, are superior to exercise alone. So this comes in down the line. So shockwave has been quite well researched, and you saw that previous slide. I think that showed, the green, sort of light green and white for level of evidence. So shockwave is actually quite an effective adjunct for pain management and function, but at medium to long term. So if you do shockwave, it's not to gain immediate pain relief. And I don't know how many of you guys here use shockwaves. I don't have one, and that's the limiting factor for me not using it. There is a practice in Port that does it, and I do refer out a bit for that. But I make it clear that it's not to control their pain in immediate time after that treatment, because quite often they come back and they say, that was quite painful. So make sure that if you do use shockwave, you tell the people that this is not a short-term game. We're looking to benefit at 3 months onwards. There's been a lot of interest in hormone therapy, and it is a field that's developing, and it's being looked at in other tendons as well as adhesive capsulitis. And the background is that we know that sex hormones are essentially act as transcriptor factors for type 1 collagen. And we all know how estrogen correlates with bone health. And essentially, this is the next step, is going, well, how is estrogen? How does it help us manage tendon health? There's not many studies. So the best one is by Cowan 2021. And again, I stole that slide from Alison, who you'd be familiar as an expert in the lateral hip pain field. And they had very promising results. So if you look, so they had 2x2 randomized control trial, and they basically went hormone therapy versus placebo versus globe exercise versus sham exercise, and put those into 4 groups. And you can see that even hormone therapy versus sham exercises were superior to sham cream to proper exercise. Don't stop the exercises, but it just shows that there is potential for hormone therapy. I personally don't use it. I think it's in a stage where there is potential, and the times that I have considered it has been essentially handed over to GP. Now, I don't know if there's GPs in the areas, but from a physio perspective, when you do start people on HRT, you've got to consider the risks and benefits, and there are contraindications to it. So I think it's not unreasonable to use it, but engage with a GP and do that in a collaborative way. The only other thing I'd add about that study is they showed that the effectiveness there was no effect on patients with BMI above 25. So if you're looking to use it, you instantly select the group that is not overweight. And then we'll get to the microinvasive. So this is the injection, so the PRP and the cortisone. And again, never a sole treatment and never first-line treatment. With regard to cortisone, it's rather accepted that it's a good pain modulator, but tends to be effective in 6 to 8 weeks. From my personal experience, I do consider it when I have seen that the patient has failed adequate quality load management program at about 12 weeks. I give them 12 weeks and then I cease. Now, I'm going to talk about the risks first, because I think cortisone does have a bad rep. We know it's detrimental to collagen synthesis and cell proliferation in the tendon, and studies in even just take common sense or origin tendinopathy shows there is actually a negative effect at 12 months compared to no treatment alone. But where I do use it is where those patients are in quite severe pain. So the pain's affecting their sleep, it's affecting their function, it's affecting their rehabilitation. So they develop kinesiophobia, they're not moving, they don't want to do the exercises because it hurts too much. And we've educated and reassured, and we're still not getting anywhere. So breaking that pain cycle can actually empower me and you guys to apply that load management strategy and actually get them moving and get them going. So yes, there are negatives to it, but again, it is a tool in my little toolbox, and I pick it when I feel that we need to get that pain under control, and we need to empower this patient to go, hey, pain's okay, and let's get you exercising, and let's start building that tendon capacity. The little comment there, that's what Angie had a stab at me about my spidey senses, about bursa versus tendon. Now, I do get a vibe in it, and I'm not saying it's correct. I'm just saying I get one where I think whether, and I'm not saying that tendinopathy is not the primary cause. I'm just saying what is the pain generator. And if clinically I have a feeling that the bursa is playing a big role in it, and I do it basically through a combination of clinical examination and experience. And the experiences, that's what we're talking about, is that quite often I'll examine the patient before and I'll examine them after an injection. Now, when I inject a cortisone, I'll always put a bit of local anesthetic. So I know who's responded well to that bursal injection immediately. And yes, there's certainly been cases where I've injected the bursa and they're like, well, that didn't really help. But there have also been cases where the bursa has been injected and they are absolutely pain-free. Yes, there's no studies about likelihood ratios and predictive powers of my clinical exam, but it comes from that experience. So if my spidey senses, because medicine is an art, tell me that the bursa is playing a role and the pain is significant and it is stopping this patient from graduating their loads and affecting their quality of life and sleep, and they're kinesiophobic, I do use cortisone in that setting. And the goal review is really important, because I always say to them, this is not to stop your rehabilitation. This is to control your pain, to allow you to continue with that. It's never you failed that, so we're moving on to this. It's we need to continue with that, maybe adjust it, but this will help you build that tendon capacity through load. So PRP has been used in other tendons, and there's some good evidence for some tendons, and then for other ones, shoulders are common. The evidence for it is quite poor. But there is moderate level of evidence for it in lateral hip pain and hip abductor tendinopathy. Now, again, this is not something I reach for early on. I tend to wait for that 16, 20 weeks. So at this stage, adequate rehabilitation. If there's a pain component, I might have tried a cortisone at this stage. And when they failed at all, I might suggest PRP. The evidence does support its effect, both in pain and function. But again, we're looking at medium to long-term goals. So we're looking at 3 months to 12 months is where you're seeing the benefit of PRP in pain and function. But the studies are all very heterogeneous. It's unclear what PRP preparation using, how many injections, well, where do you inject? I guess you inject the pathological tendon, but there's so much difference. So you can't just put your finger on what works best, and also you can't put them into a good meta-analysis and do a good study out of what's available. I use leukocyte-rich PRP preparation because that's shown to be most effective for tendinopathies. Normally, I start with 1 injection and I'll reassess them at about 4 to 6 weeks. And again, I stress to the people that I'm seeing that this is not a replacement for the load management that they've been doing. It's to assist with that. And I usually draw a little diagram about tenocytes and how they're like. There's mechanoreceptors and there's growth factors, and it's a little teamwork from both. So I try to get a buy-in that, hey, we've got something extra to help you here, and it's a little carrot, but it doesn't come at expense of load management. So this is just a little quick summary, and that paper by Wang is quite a good little summary as well. But so which one do you use and when? So cortisone, good for short-term pain relief. Is that 5 minutes? Done. 2 minutes. I'll be done in 2. Fundamentally, it's detrimental, but clinically there is value in it. And it's my little tool in a toolbox. And if I see that I'm going to get something out of it for what I'm trying to achieve, it's a useful tool. And PRP, I'm looking at long-term goals. Cortisone's contraindicated, failed, and it's more for tendon specific, and also if there's a refractory tear or tear involved. I get questions about, and Laurie's touched on this, do you inject under ultrasound? Do I not? And the main, confusion about it is that there's lots of studies that say anatomically guided cortisone injections are as effective as ultrasound guided injections. And, the evidence is pretty strong for that. And I don't disregard that. But as I mentioned before, cortisone is detrimental to the tendon. So the reason I use ultrasound guided, and I'd encourage you guys to refer to radiologists or sports physicians to do it, is not so much because I'm trying to maximize the effect of cortisone. I'm trying to minimize its detrimental effect. I don't want to inject it blindly into a tendon. I know it's going to work whether I inject it into, a shoulder or, finger. I know it'll work, but I don't want to affect the tendon health while I'm doing this. It's in reverse with PRP. PRP is much more effective when it's injected accurately into the tendinopathic site. So here, ultrasound does matter because I want to be able to see that tendon, and I want to put the platelets where they need it, as opposed to just into the abyss. So that's the reason I use ultrasound, and that's where I would, despite the evidence, which I'm not arguing against, I would refer out if you don't have those facilities to do it. Now, surgery I'll go through pretty quickly, but this is a last resort. We've failed everything, pain, function, and that's where imaging comes in. This is where I would start considering imaging as well. So it's something to consider for full thickness tear with ongoing pain and function, or partial thickness radiologically on an MRI. But we look at muscle atrophy as well. It's there are a number of techniques. They're all case series, so basically surgeons who are interested in this just showing their effectiveness. And overall, there's a number of techniques, but overall it appears that if you combine those techniques together, you get better outcomes. Now, these are really good. I hope you had dinner, but this is some of our pictures from some of our operations. So this is from Dr. Rupert Snyman, who is head of orthopedics in Port Macquarie that I assisted with. So this is just a bit of anatomy. Greater trochanter, GT. So you're looking, so I'm just going to be your patient basically. You're looking at it this way, okay? But that's the tear in the hip abductors that are being held. But remember how Laurie was saying that the tissue itself is very thin. So that's how thin the tissue is. It's not, it's not a big chunky tendon like you might see in Achilles. It's more like a plane. So I'll just guide you through them. So basically, that's the tear. That's the greater trochanter where it should insert. On that slide there on my left, that's the gluteus minimus that is a bit more anteriorly. So remember, you're facing that way. And under the gluteus medius, and that's been repaired. Then that's the repair of the gluteus medius that goes above. So that's how it looked like before, kind of like a V shape here. That's it, repaired. The minimus is already underneath and fixed. And then what Rupert does is and this is Walsh technique, so Deb Walsh in Sydney does a lot of these, does intraosseous fixation and essentially splices them back onto the greater trochanter, and that's the final outcome. And then Rupert tried to give me a video, but I was like, Rupert, I'm already running out of time. But it is interesting because you open it up and you move the femur, and the greater trochanter is basically just sliding on the tendons. When it's attached, you see the mechanism of it when there's been anatomically successful repair. So overall, putting it all back together, there are a few guidelines in literature. So you saw that slide before that Angie showed about the level of evidence for cortisone, education, shockwave, PRP. This is paper by Gamara that I don't fully agree with that pathway, because I don't think we need to separate that rupture from tendon that early, and I don't think we can. Sorry, that wasn't me. But it's not a bad flowchart. So, simple stuff from medical point of view, pain relief, load management that we talked about. You can consider cortisone local anesthetic, add shockwave or PRP. And then if we're not getting anywhere, then we've got surgical options, and that's where I would consider imaging as well. Now, we've sort of put our heads together, and there is a local pathway that we kind of proposed, is that the right word? And we'll talk about it later.
All right. I'm going to wrap up. We've got draft 1 of our pathway. So the output from tonight is that we've come together to create a bit of a pathway for how we should manage that. So after all of the information that we've put together, this is roughly what it looks like. I don't know if I can make it go without skipping through the screens. But basically, no, it's going to do it, sorry. Basically, you start with someone with lateral hip pain. You rule out whether they've got a sinister pathology. If you think that is the case, we send them for further imaging and investigations or refer. If their symptoms and their examination fit with gluteal tendinopathy, then we assess, do they have any other comorbid conditions or things that are complicating their management? If so, doesn't matter. We just treat it anyway. We don't need to freak out and go image them, because we're going to find stuff that's going to freak the patient out. So we just treat their low back pain, we treat their hip OA, and we treat their lateral hip all at the same time. We're all smart enough to do that. We can manage that. If it's a simple case of lateral hip pain, great. We still don't image. We keep initiating that first line management, physiotherapy, education, advice, anti-inflammatories if needed, all that activity modification stuff that Cate was speaking about. Do they respond to the treatment? Yes, great. We proceed. We keep adding load. We make it harder. We know tendons like load. If it's appropriate, move towards plyometrics, get them back to their meaningful functional task. If they respond to that, yay, they're better. If they don't respond to treatment, Angie's saying, let's stay in that cycle a little bit longer. Let's be a little bit uncomfortable as the physio and hold the patient's hand. Are they doing the exercises properly? Are they following the advice we've given them? 9 times out of 10, they're not. They're doing the exercises incorrectly, inappropriately, too much. It's the wrong exercise for them. We can modify that and make some changes. If they respond, great, they exit out of that program. If they're not responding again, we look at other adjuncts, shockwave, orthotics, dry needling, fucking whatever, taping, whatever other tools we've got in our kit. Can we help in any other way to get them better? If still nothing happening, we always have to go back and reassess. So we go back up to the top again. Are we confident that our diagnosis is right? Are we missing something? Have we stuffed up somewhere and forgotten something? Enter back in. If not, can we refer on, get further imaging to exclude other diagnoses? Should we get a sports physician or somebody else involved? They can do things like diagnostic local anaesthetic injections, really confirm the diagnosis of some sort of gluteal tendon or bursal pathology or something that's driving their symptoms. Do they respond to that and it confirms it, or they don't respond to it and they go back through that cycle to work out what else could be going on? If they respond, let's talk injection therapies, potentially working together with our first line management as before. So should we PRP? Should we cortisone? We spoke about the short-term benefit versus long-term detriment of using cortisone. PRP, if it was more cost affordable for people, it would probably be more of a better option than cortisone. Did they respond? They can do that a few times. If they're not responsive, surgical review. Benny, agree?
Yeah, the less of these that I have to see, the better.
I knew you were going to say that. Yeah, Ben wants them in that little group just floating around down there for a long time. And similarly with sports physicians, they don't want to see them when they've done 3 sets of glute bridges and they're not better. Like, Andre doesn't want to waste his time saying, go back to the physio, like, you haven't had a decent crack at, you're still doing compressive exercises and things that are making it worse. So go back to the beginning, go again. So let's sit with these people a little bit longer and be confident, like Laurie said, be confident our diagnosis is right. Most of the time we're right. We just have to choose our exercises better and hold the patient's hand a little bit longer. I threw this slide up here because, we're very grateful that we've got our partners and things that make these events free for all of us to come to. I'm a big believer in removing the barriers to research translation and not making these things costly. We are a charity, so we're welcoming donations. So if anyone is happy to donate, we can start sharing these QR codes. And if you're a clinician and you usually go to these professional development events and you pay to go to them, and these things are free for you to attend, and you think it's worth some money to pay, that will go towards funding things like developing those outputs and going into GP education and these sort of things to make local change, that would be great. And we're also running a member survey. We haven't done a survey in over 2 years, and we've got an extra 200 members or something that we had compared to 2 years ago when we did this. So it's really important that we understand, the committee understand what you guys want to know, why you want to be part of this network, what things you want to change locally with, musculoskeletal healthcare. So if you can all take some time, we're probably running low on time, and I don't want you to rush through that survey. So this will come out in a newsletter in the next couple of weeks with a summary from this evening. So if you see that come through in the newsletter, please click on it and fill it out. It takes about 10 minutes. If you're a new member and you know nothing about Ripon, it won't take you much time at all. If you've been part of Ripon for a long time, Ben, you have to fill it out. If you've been part of Ripon for a long time and you've got a bit to say, take a bit of time and fill that out properly for me. That would be much appreciated. That's me done. Thank you.